Good. Last one coming in. And then there's some chair. Oh, there's another face. Nice. Another one. Excellent. Okay, well, I'm gonna start. So, because it's 4 o'clock Copenhagen, Stockholm time, it's time for Graham's last webinar 2021. Oh, it's been so good. We've had so much good feedback on these webinars. So, but now it's time for Graham to have a break and enjoy life a little. So I have done my duty to keep you entertained for the next 2 months I have covered. So I'm just gonna just introduce you to my plan. So on the 13th of January, we are gonna do metabolomics with Warren Brown. He's gonna catch up where Graham left. And I'm hoping I can bribe him to move a little bit more into the fatty acid blood spot as well. So that's what we are planning there. Then on the 27th of January, we are going to have an introduction to a test called TrueCheck. And TrueCheck is a blood test that measures for, hold on, 75 different solid tumors. So it's a cancer screening test. That's very, very interesting. So we will have an introduction to that. And on the 3rd of February, Tom Baines is coming back. Last time he spoke about megaspore biotics and probiotics. And I have asked him to move into how do we heal the leaky gut with some of the products they have. And then last but not least, so far that is planned, is the 17th of February. And that's going to be on nucleotides. And most of you probably already know the nucleotides products, but I have invited Peter to go much more into details as why is it this product is good. We have a short introduction on VMS, but now you will have more time with Peter Köppel and him going through all the more like nitty-gritty details in the product. So stay tuned. 2022 there will be education gifts as well. And then one thing more I want to tell you is that the Grow Baby training program is now live. We're going to send out newsletters on that, so you can buy that. I've been through it now, looking at it, and it's very detailed. So look forward to that as well, and maybe put some time in the calendar for education for these moms to be. So we are recording. Recordings will be shared, and it will be put into VMS. And Graham will send me his slides, and we will share those with you as well. So I'm gonna zip up and pass on the stage to you, Graham.
Okay, great, thank you. And well, nice to be back, but sad it's the last one of the year, but also exciting for a bit of holiday, bit of time off, so refresh the brain a little. So today, of course, we're talking basics regarding metabolic testing. So usual session goals here, just to understand where it may be helpful, what we can learn from the tests, and some basic interpretation and treatment strategy options. Now, I think this diagram really summarizes why we want to be doing some kind of, at least some basic cardiometabolic testing, because we can clearly see that cardiovascular disease really dominates the top causes of death worldwide. And also I think that sometimes it does get a bit forgotten about within personalized and functional medicine, because we're seeing patients that are coming with a whole variety of symptoms, not usually, of course, like typical cardiovascular related symptoms, because normally when patients get cardiovascular symptoms, in most cases, it is a sudden heart attack. So of course, it's nicknamed the silent killer, because patients can have cardiovascular disease occurring and we don't know anything about it. There's no obvious signs or symptoms until, of course, they end up in the hospital with their first heart attack. And then, of course, usually with first heart attacks, there's a very high rate of death that actually occurs from those first one as well. So I think it's a really important topic for everyone and anyone who's interested in longevity, health span, and lifespan. You should really be looking at cardiovascular disease because, well, that's statistically speaking, the main disease that is going to affect ourselves or our patients. So I always generally try and include some kind of at least basic cardiovascular screening in our functional medicine screening sessions. Some very basics like blood pressure and weight, height, BMI, body fat levels, truncal obesity measurements, things like that. Because of course, in regards to the long game, that is where most of our patients will likely get caught. So we want to try and catch that early. It's much easier to prevent cardiovascular disease than it is to actually treat it once it's happening. Although in medicine, of course, there has been a lot of development over the decades on actually various medications that can extend life once a patient has cardiovascular disease. But of course, we're not really interested in that. We want to prevent it in the first place, or at least certainly reduce the risk of that for as long as possible, well into later life. So without going into excessive anatomy and physiology and the background of cardiovascular disease, to keep it quite simple for today, to get through the tests and some examples, I mean, really there's four main contributors to cardiovascular disease. We have number one is lipids, number two is inflammation, three is endothelial health, and four is metabolic health. And if you want to prevent cardiovascular disease, if you want to reduce risk, you've got to work in all four of these areas clinically. There's no point just focusing on one, although of course we can lower lipid levels, it's going to help to reduce risk. But if you're not addressing inflammation, endothelial health, or metabolic health, then it's not going to be as successful. So really think about these four different areas when trying to either evaluate cardiovascular risk or reduce cardiovascular risk. So if we look at the first one with lipids, so of course, atherosclerosis, this kind of inflammation and damage of the arteries, first and foremost, it's driven by lipid levels. So I'm not talking necessarily about cholesterol here. I'm talking mainly about lipids and particle counts. And this is where things like apolipoprotein B is much more superior a test compared to LDL cholesterol, for example. Because with apolipoprotein B, we're getting a window into the actual particle counts of the lipid molecules. And that's more important than just looking at cholesterol levels. So in regards to lipids, from the research and data, we generally see that apolipoprotein B is the most important, along with what's called Lp(a) or lipoprotein (a). And then we have like VLDL remnants. So VLDL and IDL, these are different different size particles. So VLDL, very low density lipoprotein, for example. So when you're doing a lipid screen, these are the ideal 3 to include if you can, but VLDL and IDL are much harder to get on standard tests. We need to go to some of the more advanced tests to grab those, compared to apolipoprotein B and lipoprotein a. In regards to inflammation, I mean, there's atherosclerosis. It requires inflammation, if you like, to develop. So we want to gain an understanding of the inflammation levels within ourselves or our patients. And there's lots of inflammation markers, but not many are actually specific to cardiac tissue. So we have non-specific markers, meaning they tell us inflammation is going on, but it's not necessarily in regards to cardiac tissue itself. So high sensitive C-reactive protein, we have fibrinogen, and then we have a variety of interleukins that we can use. And then we do have a very specific marker of cardiac inflammation or cardiovascular risk of inflammation, and that's oxidized LDL, and that can be done with our Liposcan panel and oxidized LDL. So that's a really nice specific test if you want that information. So of course, we want to know the lipid levels, we want to know the inflammatory state in the body, and then we also want to know risk of endothelial dysfunction. So when we get impaired endothelial function, again, it's going to play a role in that kind of cardiovascular disease process. So things that irritate the endothelial lining, like high levels of insulin, so hyperinsulinemia. We've got elevated homocysteine, elevated uric acid, and then impaired kidney function. Now, it's not so often where we will get patients with impaired kidney function, but certainly when running a lot of standard blood tests that we do on our patients in general in Stockholm, we will quite regularly find, if you like, borderline high or high homocysteine and high uric acid. So we want to get those down as well as insulin levels, and we want to optimize kidney function to prevent damage to the endothelial lining. Then, of course, we have metabolic health in general, and this is a huge part of the disease. Of course, glucose levels, insulin resistance, triglyceride levels, and again, impaired kidney function. So we know very clearly that if we want to reduce risk of all-cause mortality, not just cardiovascular disease, but cancer, we want our patients to be metabolically very healthy. So nice low levels of insulin. We want very generally, again, low normal levels of glucose, so we're not reaching that kind of insulin resistant stage. We want lower levels or lower test results of things like hemoglobin A1C. We want to make sure that they are metabolically at very low risk of diabetes, especially type 2 diabetes in particular, because of course we all know that that will drive up cardiovascular disease risk. So when we're looking at these different areas, the lipid levels, inflammation, metabolic health, endothelial health or dysfunction, we have a number of tests available in the system that can help to analyze that. Now, one of the largest tests that we actually have in the system in general is called Cardio-ion. And this is best used if you want risk markers combined with nutrition analysis. So it's a very extensive test that covers both areas at once. So if your patient wants very detailed information, you want things like organic acids, amino acids, omega 369, red blood cell, magnesium levels, things like this, toxins, as well as your cardiovascular disease risk markers, then this is a fantastic test to run. Downsides are it's pretty expensive. It's around about €1,000, so not all patients are going to be able to do it. You need to get a serum sample, and it doesn't contain things like ApoB, doesn't have oxidized LDL. You don't get things like fibrinogen as well in that test. But that's one of our kind of most thorough analysis, not necessarily on cardiovascular risk itself, but a combination of both cardiovascular risk and nutrient levels and how those nutrients and situations could be affecting cardiovascular risk. If you don't have the ability to get a serum test done, then we have what's called the Cardiometabolic profile. It's a blood spot test. I'm going to go through that in a minute. And that gives you a nice, like, general basic overview of some of these key markers. I think probably the best overall option when considering costs and information is the cardiovascular risk profile, but it is a serum test because we can't get things like oxidized LDL from a blood spot. We can't get lipoprotein Ldl from a blood spot. So this is probably the best option overall if you want to do a risk profile within our Nordic system. And then we have what's called Liposcan and oxidized cholesterol, and that's best used for a deeper insight into lipids and oxidation. So it's the only test with both VLDL and IDL, and where you can collect this oxidized cholesterol all in one analysis. And it goes into the different LDL particles and how much of each particle the patient has. But of course, the downside with that one is you don't get things like ApoB, lipoprotein Ldl. There's no endothelial dysfunction factors and no inflammation levels. So again, as with all tests, there's pros and cons, and there's like highlighted spots and there's blind spots. So you need to decide what you want to actually look at and how much you want to evaluate. Then we do have, there's the DNA health panel, and we have also a genetic panel called Lipid, and they only look at the genetics, but that can help to explain why lipid markers are elevated, or it can of course be done to see from a preventative perspective, okay, your patient has a much increased risk of inflammation and higher cholesterol levels, for example, that may then prompt or encourage that patient to then go and do some further lipid testing to actually see what's the phenotype. So just remember, of course, those genes, they don't give you any data as to what's going on now, but it's just telling you the coding to what is likely to happen. So just to go through these tests, I've just taken some snippets of the cardio ion panel. There's a lot of information included in that test. So here we can see some of the lipid markers, but I'm really not a huge fan of doing like LDL cholesterol anymore. I think that apolipoprotein B is a much better indication of cardiovascular disease risk. But this goes into these lipid markers. You get lipoprotein Ldl here, you get additional things like ferritin, obviously you get fibrinogen, C-reactive protein, we've got insulin, things like testosterone as well. And then we get more into some like nutrition markers like red blood cell, magnesium. And then we've got endothelial risk markers like homocysteine. And we get more and more into the nutrition as the test goes on. But you see, you get a lot of data with this test that can really cover that whole area of cardiovascular risk and nutrition markers related to cardiovascular risk. So really nice test, but quite expensive. So if you've got a very detail-oriented client who's willing to spend, of course, the money, then it can be a fantastic tool to use to help to answer certain questions. Then we have the cardiometabolic profile. So it's blood spot, really nice, can be done anywhere. Don't need a nurse or a doctor to draw blood. Here we can see, for example, I mean, once insulin is really getting above 5, so a fasted insulin level, then going to start to get a little concerned. Don't want it to get much higher than that. You see C-reactive protein here, nice and low. But then, of course, we've got high hemoglobin A1C, we've got high triglycerides, high cholesterol, and we've got low HDL, high normal LDL, and high VLDL. So we can definitely see risk here being increased, driven by lipids and also metabolic health perspectives. We've only got one marker of inflammation, which is low, but of course that's only one marker. It doesn't tell us the whole picture. So here, of course, we've got a lot of different strategies we could use for this patient, but fundamentally we're going to look at their diet. We're going to be trying to reduce their weight. We're going to be looking at carbohydrate intake. We're going to be looking at fat intake as well. And one thing that I'll get into a bit more later on is like diet selection based on certain results, because sometimes we will use kind of a low fat diet, kind of the more old school type thinking in regards to heart disease. But of course, a lot of the newer information and research, and over the years, we've seen that, of course, it's not always, and probably quite false, that saturated fat drives heart disease. We're going to be looking more at Western diets and carbohydrate intake and sugars and things like that. But this patient clearly at risk, we need to get that risk down. Of course, that can be done medically. They could take medication. Things like a statin could help to drop those levels pretty immediately. But of course, there are side effects with statins, and all of these things need to be discussed with the patient and understood. What can the patient do? Can they make the lifestyle changes necessary or not? Are they prepared to do it? So again, in the clinic, we're not against using medications where needed, but we're educating our patients about the pros and cons of each of the different options. And of course, we are really pro lifestyle and behavior and nutrition, really ahead of course of medication where possible, but we've always got to look at the risks involved and try and weigh that up. So then we have this cardiovascular risk profile, and this is a really nice one. They say it's probably the best overall, like rounded test, not for a kind of reasonable price. It's not very high end, it's not very low end. I think it's about 350 euros for this test, but we're getting the cholesterol levels, we're getting oxidized LDL, we're getting lipoprotein Lp(a), triglycerides, we're getting homocysteine, C-reactive protein. So again, it's generally a nice overview of the lipid situation and inflammatory marker as well as endothelial health. So quite a nice balanced test in some ways. But again, it's a serum test, so you need to be able to draw blood or get blood drawn by a nurse or doctor or phlebotomist to be able to run this test. We have what's called the Liposcan and Oxidized Ldl. So here we can see the subfractions of LDL, because there are 7 different subfractions, and LDL 1 and 2 are considered less pathogenic than LDL 3 to 7. So we're actually getting counts on that. So it's a much more in-depth analysis of these pathogenic subfractions, plus you get the VLDL and IDL levels, along with total cholesterol as well. And then really a nice kind of add-on to this test is you can run oxidized LDL as well. We can see here, this is nice and low, below 90. So we're not worried too much about, in this example, about the cholesterol being oxidized. There's a lower risk, even though the cholesterol is high here, VLDL is elevated, so we certainly want to lower that. But on first instance, looking at this, if we just did a total cholesterol check, might be, oh, this is very concerning, cholesterol is high. But once we get more into the data, we can actually see this is maybe not quite as concerning in the kind of first view, because we can see there's no pathogenic LDL subfractions, but of course that VLDL want to be a little bit lower, and LDL not always the greatest measure. We want to really have the apolipoprotein B, because again it's more these particle counts which are more important, and that's where the lipoprotein B gives us a better insight. So if we go into a 2 case presentation, so the first was a 71-year-old male who has retired, but he was having many joint and musculoskeletal pains. He had been diagnosed with rheumatoid arthritis. He was on medication for that, methotrexate, just general inflammations, and he had suffered a minor cardiac event prior to coming to the clinic. So we wanted to reduce his cardiovascular disease risk. We wanted to see, can we improve this joint pain that he's having? So yeah, cardiovascular disease runs in the family, father, grandparents, also, yeah, we can see very clear family history going on, but dementia, strokes as well. So we know he's an at-risk patient from that perspective. We can see not much going on with the timeline here, very few events, although this might just be a male reporting this stuff, basically, until things really break, they consider themselves fine. So not much going on with the timeline. When we start to look at the matrix, it's more the defense and recovery. So that was the main area, as well as energy and a bit on communication. But definitely too little sleep. His exercise was great overall. He was eating standard Swedish diet, which is certainly better than the standard American and British diet. Having lived in both countries, I can vouch for that. So not too bad a diet, but could be a lot better. Fairly high intake of grains. Long history of possible excess stress, but wasn't really too forthcoming about what. We can see here then in the MSQ, not much going on, high scores in joints and muscles. Sorry, all the non-Swedish speakers on the call or Scandinavian language speakers, but main thing here, yes, joints and muscles, highest score here, not surprising given his diagnosis. Of course, rheumatoid arthritis, inflammation driven, more inflammation in the system. So that's not going to be good from a cardiovascular disease risk perspective as well. So we We ran some started tests. So when we run standard blood tests here, and we use a local laboratory just to get some of these standard analyses. We can see his ApoB was right on the borderline of normal. So his particle count is not too high, but it's certainly not great. But then his uric acid well over the normal range. And then we can see lipoprotein Ldl was very elevated. So there's definitely a big lipid element to his risk, as well as some endothelial dysfunction. And his CRP is 2.5, which is too high for my liking. I like to see that under 1. So there's inflammation going on, as well as his insulin level is it's not terrible, but it's not great. And once that starts to get closer to like 14, then we're definitely getting into insulin resistance. And then fibrinogen, so this coagulation marker, was elevated as well. So we've got a nice cocktail of lipids, inflammation, some minor metabolic components, and endothelial dysfunction going on. So what I did with him is that I gave some B12, B6, and folate. Wanted to try and target, especially, let's see if we can get the homocysteine down. Moved him more to a paleo diet that I had to convince him was for only 3.5 weeks, because he was very concerned about not being able to have some of these foods. Took away purine rich foods, tried to get him off all fructose sources, really reduces alcohol and shellfish because they're much richer in things which can basically increase the uric acid level, and then got him into a time restricted feeding window. So that was the first main things that we did with him. And then we retook some of these markers, so we could see now homocysteine was much better. It was under 15, which is a great start. Really, we want to get that under 10. You can see his uric acid had now fallen into the normal range. It's still higher than where I'd like to see it. And his triglycerides were much better. And quite, astonishingly, I mean, his, or maybe not too surprising to most of us on the call, but with the change in his diet and these improvements, I mean, he had 0 joint pain. He'd gone back to his doctor, and he'd removed his medication in that time. So he was just feeling much better, although we've still got a long way to go to try and also improve the other lipid markers, but it just really shows how powerful things like diet change can be in short periods of time. Then we have next case here, a 45-year-old male, no cardiovascular event, but had been for a work-related health assessment, and they'd found high cholesterol. So he was quite worried, and he just wanted to lower his cardiovascular disease risk. So he came to see me at the clinic. Didn't have any questionnaire for him. He didn't do it before he attended. Doesn't happen very often, but he hadn't completed the living matrix. But there was cardiovascular disease in the family. No signs or symptoms. He was just coming from a purely proactive perspective. So wanted to run, of course, a lot of standard tests, but also always interested in the stress response, and stress, of course, has been linked with worsening of cardiovascular outcomes through a variety of methods, through increased cortisol and sympathetic nervous system drive. So not only did we do oxidized LDL and Liposcan, but also a Dutch plus to see how that was. Of course, we ran the standard blood markers here, so we could see his lipid levels. His lipoprotein Ldl was good. His CRP inflammation was nice and low. His insulin was good. Homocysteine bit higher than I would like to see it, but it's okay. It's not terrible, as well as the uric acid. But here we have the triglycerides, quite good, very good actually. And then apolipoprotein B, a little bit high. So there is this, that's just a standalone risk factor in regards to lipids. So we want to understand what's driving that up. And then for fibrinogen, good there, so no. So really, so far, it's mainly only lipids that are driving this and some optimization of homocysteine. And then when we looked at his Liposcan panel and oxidized LDL, we can see oxidized LDL was nice and low, but there is some pathogenic LDL particles going on here. VLDL is increased. So yeah, here we can see his total cholesterol. This is what's been flagged up on his work health assessment report. So yeah, mostly it's lipoproteins that are driving this. And then I also ran a test looking at these levels, or these sterols and stanols, which can tell us what's going on in regards to digestive uptake of cholesterol. So when we see high beta cytosterol and campesterol, then it can tell us that basically this patient is a big overabsorber of cholesterol from the diet. So it's not necessarily production markers. So of course, what would probably classically happen in healthcare is say, well, your cholesterol is high, we're going to put you on statin, and we're going to reduce the production heavily in your liver. But what we can see from this test is it's not a production issue with him. He's a hyper absorber through the GI tract. So that was really an interesting finding. We can see from his Dutch plus here, just a Dutch adrenal, that his metabolized cortisol was very low, and that normally indicates a thyroid issue. So varying degrees or varying types of thyroid dysfunction. Of course, if we've got some kind of hypothyroid state driven by either a lack of thyroid hormone or interference with the receptors, that can also affect clearance of cholesterol. So always check your high cholesterol patients for hypothyroidism, because it can just be in some cases it's hypothyroidism driving high cholesterol. You can also see his free cortisol patterns quite high. So there's definitely a little bit of a stress component going on, but it also could just be if he's not basically metabolizing that cortisol out through the system quickly enough, then it could be being like backed up in the saliva. So when we see patients like this, we either use like Bergatone, which has a similar effect to ezetimibe, which is the medication that we can also prescribe to block absorption of cholesterol from the diet. We want to follow up with thyroid testing to check what's going on there. Is it nutritional deficiency? Is there some early stage autoimmunity? Just what's going on in general. And then this would be, while we're trying to resolve this and really understand what's driving it, and can we change the outcome in some way, going to move in more to a lower cholesterol diet. So this is more the old thinking in regards to how patients should eat to reduce heart disease risk. And we're going to increase his fiber also to try and block excessive cholesterol absorption. And then just talked about some mindfulness meditation, 10 minutes per day, which we've seen very, very effective at helping to change things like free cortisol levels. So I thought these were two really nice examples of both like newer type of thinking with nutrition approaches and some older type of thinking, and how to clinically reason where you might do one or the other. And of course, that's where the tests are very helpful to understand what's actually contributing to this and how does that allow us to make better clinical decisions and interventions rather than just going with mass data or a general thought pattern that, oh, this patient could have been told, this second one, you should do a high fat diet, and that could make his cholesterol levels most likely a lot worse. So again, this is where the personalized approach really can come in quite nicely. Okay, so we're over to some questions now.
Super. So one question that came on, which was just the last one, was if you would consider like viral illness, acute or chronic, like Epstein-Barr, gut with a microbiome, and liver in the mix of your treatment.
Well, there was a lot of parts to that question.
Well, let's take the first one then. If there's any viral illness, it could be like a chronic EBV or CMV.
Yeah, I mean, we quite regularly take those markers, usually using ELISpot analysis. But I wouldn't classically include those in a standard cardiovascular workup. So we're looking more at the viral reactivation factors, more in fatigue and brain fog, and those type of situations like long COVID, ME, CFS. So they certainly wouldn't be part of my standard workup for cardiovascular risk. But if the patient was also showing a lot of other symptoms of possible viral reactivation, then we would look at it, and we would use classically ELISpot testing for a suspected chronic infection. Okay.
So there was another thing, like if a patient is on statins and the lipids are normalized, would you then consider oxidized LDL, or would you wait and if then to take a break on statins and then see, or how would you address such a situation?
Well, I think I went through the 4 components of heart disease risk. So when there's lipoprotein, I mean, there's always going to be some circulation of lipoproteins, regardless of whether you're on a statin, which of course is going to push those down quite heavily. But if you have less lipoproteins in circulation, then cardiovascular risk is generally going to be less. But if they still have high inflammation levels, if they have high factors that are going to irritate the endothelial lining, high blood pressure, high uric acid, high homocysteine, then those need to be looked at and those need to be addressed. Because even if you've got low lipoprotein levels circulating around, if there's high inflammation, if there's endothelial disruption and dysfunction, it's still going to drive cardiovascular disease.
Super. And then one came up about, again, the mechanism of action in regards to hypothyroid and cholesterol. You showed on the Dutch, like, more about the mechanism of action, or can
Well, it's just, of course, the thyroid hormones drive metabolism in general. So metabolism of lots of things slows down, including cortisol through the liver and including lipids out of the blood. So once you're in a hypothyroid state, all of those things will slow, including many other factors. We know skin, hair, nails are affected. We know that nutrient levels are affected. So that's the problem with hypothyroidism, is just the clearance of cholesterol becomes very slow, so it builds up more in the blood.
Excellent, thank you for that. Yeah, I had another, that was myself, because we also have the Cytodx test with all
Yeah.
the interleukins and Th1,
Yeah.
Th2 response and so on. Would you consider that in this picture?
I think well, I've been very interested in cytokines over the years, but I think the problem is, I think the challenge with the cytokines is that it's a very quick snapshot, and you're looking at these like downstream metabolites, so whether interleukin 6 is high or whatever it is, and it might be that it's high in tissue but not in serum. It's hard to capture. So you could use the Cytodx profile, but it's when you see high levels on there, you're still going to be reverted clinically back to, well, what's driving this? Of course, it can be, well, we've looked at that, especially in autoimmune disease. Well, we can see high Th17, we can see Th1 status going down, Th2 increasing. But still, that's driven by infection, it's driven by dysbiosis, it's driven by stress hormones, it's driven by inflammation in the body in general, brain inflammation. So my strategy, although I've dabbled in a lot of cytokine testing, has been, well, I've just clinically decided not to use that as much, because it just gives us a status. It's a bit like hyperpermeability of the gut. Here's the level of the hyperpermeability, but you've still got to do your detective work behind it as to what's driving it. I think that's where the cytokines, also says, here's the situation, but I'm going to use not all of our patients have the money to be able to do all tests possible. So I'm going to pick something over a Cytodx test in most cases, because I think the clinical value that the patient's going to get is going to be more with a Dutch plus or a dysbiosis profile, or a cardiometabolic test, lipid levels, etc.
Super. That's it in regards to questions. So I think you've done a really good presentation, Graham, and it was excellent with the 2 cases demonstrating like more theory and putting it into practice, and also the different patterns and areas that you were addressing in regards to 2 different patients. So yeah, you passed your 2021 exam by doing all these webinars every month. So and people are beginning to say thank you. So Graham, thank you for all this. We will see Graham next year again, that when he recovers from his you're going on honeymoon.
Yes. Yeah. Bit of sun after Stockholm's -16 the last few days. It's not been too enjoyable to be outside.
So that's very well needed for sure. And to all of you, I think it's still a little bit early saying Happy Christmas and New Year, but to those that I won't have contact with in then, which is probably most of you, enjoy the time off. And I hope to see you in January, the 13th of January, for the first one, and throughout the year, of course, as well. Reach out if you have questions, if you need support, and we, of course, will share the recordings and the slides with you all. So take care.